And if we can start off with, or whoever would like to start off first, please state your name and proceed. Thank you.
Thank you, Mr. Chair. With your permission, I'll begin. I'm Eric Reslock. I'm the Assistant Director for Legislative and Public Affairs at the Office of Statewide Health Planning and Development, called OSHPD, or sometimes OSHPOD. With me is my colleague, Linda Onstad-Adkins, who is the Acting Deputy Director of the Healthcare Workforce Development Division at OSHPD. We're here today to provide a brief overview of the Workforce Education and Training, or WET, component of the Mental Health Services Act, and some information on provider shortages in the public mental health system. The WET program aims to address mental behavioral health workforce issues in California's public mental health system. The professionals trained and retained through the WET program serve the underserved and unserved populations in California. Quick history, the Mental Health Services Act, Prop 63, passed in November of 2004 and included a component for workforce education and training programs for the public mental health system. The former Department of Mental Health developed the first WET 5-year plan covering the period 2008 through 2013, as well as a 10-year expenditure plan. In 2012, the WET program was transferred to OSHPD, which was mandated to develop and implement the second WET 5-year plan, which covers 2014 through 2019. So in January 2014, $114.7 million was approved by the California Mental Health Planning Council for expenditure in the current WET 5-year plan. The Planning Council also approved 7 categories for expenditure for state programs, and those categories are stipend programs, which provide stipends to graduate students who plan to work in the public mental health system, the Mental Health Loan Assumption Program, which offers a loan repayment of up to $10,000 to mental health professionals working in the public mental health system in exchange for 12 months of service, the Education Capacity Program, which funds residency and training slots in psychiatric residency and psychiatric mental health nurse practitioner education programs to increase their capacity to train residents and provide clinical rotations in the public mental health system. Next is we have the Consumer and Family Member Employment category. This provides funding for activities that lead to increased consumer and family member employment in the public mental health system. Next, regional partnerships provide funding to 5 regional partnerships that are charged with developing and implementing public mental health care workforce development strategies that align with the WET 5-year plan. Next, number 6 is recruitment, career awareness, and retention, which provide grants to develop pathway programs to expose students to careers in mental health. Also provide clinical rotations and develop programs for retaining the incumbent workforce. Finally is the evaluation category of the mental health workforce education and training needs and the programs currently being implemented. Transitioning to needs and the idea of shortages, in 2013, before the 5-year plan was developed by OSHPD, OSHPD conducted a public mental health provider needs assessment and reached out to counties to identify their highest need, as well as their hard to fill and hard to retain mental behavioral workforce positions. A total of 41 counties participated in the survey. We went back in 2015 just to see if there were any changes. And there was an increase of 2 responses by counties, so we had a total of 43 participating in the 2015 survey. So the positions identified as the top 5 highest need, and these are also the hard to fill and hard to retain positions for the public mental health system are psychiatrist, licensed clinical social worker, marriage and family therapist, psychiatric mental health nurse practitioner, and bilingual workers. So at this point, I'll turn this over to my colleague for more on why these shortages exist.
Linda Onstad-Adkins. I'm going to give you some reasons for why we believe that there are these shortages. I do want to make mention of the fact this is in the public mental health system. That is what WET addresses. And most of them have already been mentioned, but I want to reinforce that some of your guesses were right. The Affordable Care Act, of course, has been implemented. That has created a greater need. We see that that need is going to do nothing but increase over the next few years. And there'll be a greater need for the providers. There's a need across all of California, but as one of you mentioned, the rural communities have the greatest need. They have both geographic and economic issues that come into play. The challenges of the rural communities include low wages, stigma around mental health, burnout, lack of jobs and promotional opportunities, quality of life for providers and their families, and other general recruitment issues. In addition, California's changing diversity or diverse population also creates a need for building a more linguistically and culturally diverse public mental health workforce to better address the underserved and the unserved populations in California with their mental health needs. I would like to also mention that WET is in the process of a more in-depth needs assessment on the provider workforce. That is due to come out probably April or May of 2016, so it's right around the corner. I'm not quite sure what else you'd like to ask, so go ahead.
Okay, thank you. Is there any questions from any of the members? Senator Bell?
Yeah, is there any way we can look at like a 10-year projection of the need based, like look ahead so we can start doing planning in our, maybe develop a plan like you want to do. You've always talked about this. Senator Hernandez has been a leader on this, to develop like a long-range plan. Now, can you address that?
Well, you're not the only ones that want it. It is, in fact, in great need and great demand today. But in terms of being able to provide it to you in the near future, we are probably behind in collecting the data that is needed to do this. But it's being collected now, let me tell you that. So yes, I think in the near future, we will be able to have the data that we can actually expand out or trend out on, but at the moment, I wouldn't want to offer you a 10-year trend.
Senator Mitchell.
You're begging for permission to ask the question since I took a pass initially, but it was something she said that triggered the thought, so forgive me, Mr. Chair. We hear all the time, and we talk about it in Health Committee and Budget, the underrepresentation of primary care physicians, and I know that's an area. Do you have a sense, for the lack of a better term, kind of a ranking of need?
Okay.
You see what I'm saying in terms of, I know we're down, if it weren't interim, I'd remember the number. For every 100 Californians, we have X number of primary care physicians and we need X number. Do you have a sense of the mental health provider kind of spectrum where it falls in terms of our deficit statewide? You follow me?
Well, in terms of the public mental health system, we know what the needs assessments have told us is the professions that are most needed. And of course, Eric mentioned the top 5. In terms of, you mentioned primary care, and that's another issue. I can tell you that OSHPD is putting together, we also have the Song-Brown Commission. We also have HPEF,
Right.
Health Professions Education
Right.
Foundation. So we are working on primary care.
I just use primary care as an example.
Yeah.
That's the one we talk about a lot in this realm and we know. So I'm trying to get a sense of where.
Well, that's what we're hoping this next needs assessment does.
Okay.
Yes.
To give us a sense
because
of where it falls.
It is definitely needed.
Got it. Thank you.
So, first of all, thank you for being here, and I know this is dealing with the public mental health system, and my staff try to figure out where we can get information in the private sector, which was very, very difficult. So, I mean, obviously, we'd like to use the data and the information you gave us, because I would think and I would assume that would be extrapolated into the private sector as well. And everything that you've said has always been what my concerns were, but we haven't been able to validate it, which is rural communities, poorer communities, obviously the distribution. And when you mentioned the top 5, I mean, it seemed like that's obviously a problem as well. And I guess my concern, and I guess my question to you would be, you know, how do we, and I really appreciated some of the comments that our first speaker, Patricia Wenzel, mentioned with regard to, you know, increasing transparency in the process, but more importantly, you know, to get more mental health providers and encourage them to come into the field and encourage them and to go into these particular areas. But what suggestions do you have to increase those particular areas? I mean, how would we get more individuals to go into mental health, to become psychiatrists, to become psychologists, become nurse practitioners, and especially in mental health? Any suggestions? Any thoughts?
As Eric mentioned, WET does provide different programs, such as stipends program, which is for those who are in the education system at this moment looking at mental health careers, providing them with a stipend to move forward, and they are provided that stipend in exchange for working in the public mental health system. We have something similar to that with the psychiatric residency programs, the psychiatric nurse practitioner programs. The mental health loan assumption program, MLAP, actually provides up to $10,000 in loan repayment. What I can tell you anecdotally is that we know that a lot of the private employers are now starting to come up with their own loan repayment programs, their own stipend programs. We know the counties have been doing this for probably the last at least 3 or 4 years. You know, the issue is often it's low wages and the debt load. You've got these professionals, even with a marriage family therapist, that often has a debt load of $140,000. And in a small rural county, they might be lucky to make $30,000 or $40,000 a year, if that. What is also often forgotten is they bring a family with them. And what is the quality of life for that family? And will their spouse be able to get a job? So there's many issues that go into play. But I do think that from the public mental health system's perspective, we are making a dent in this. We do feel that the response or the feedback we're getting from our stakeholders, including the counties, is that the programs we're providing is in fact helping to increase those coming out of the educational system. It's also helping to retain many of those mental health providers. But the reality from where I'm sitting is there still doesn't seem to be enough.
Okay. Let me just follow up, I think, in what Senator Mitchell, I don't know if I ever heard the answer, is ranking the need. I mean, and you had mentioned the top 5. Where do you think the highest need is? And relist those 5 again for me, if you can.
Sure.
Because you had said the top.
This is the 2015 survey.
Right.
Psychiatrist, licensed clinical social worker, marriage and family therapist, psychiatric mental health nurse practitioner, and bilingual workers. So those are both the highest need and the hard to fill positions.
So where
they
do
came
you
out
think-
identical.
Where do you think the biggest demand is and the greatest need? I mean, is it psychiatry? Is it licensed social workers, MFTs? I mean, where do we have the greatest shortage of?
Well,
I mean, within the public mental health
the part
system.
that's a challenge is it almost is county to county. So where you have one county that has, I don't know about plenty of psychiatrists because they're in short supply, but they have a good amount of psychiatrists. You might have another county 2 doors down that can't keep any psychiatrists. So it really depends on where you are in the state of California and which county you're in. But probably if I were to take a stab at it today, I would say it's the prescribing mental health. So psychiatric nurse practitioners can prescribe drugs. Obviously, the psychiatrist can too. That seems to be the 2 professions that are very hard for any of the counties to hold on to. I have one county that is, for their population or their county workforce, are supposed to have 12 psychiatrists, and this last year they lost 6 in like 2 months. And as they were filling up their positions, they were like losing them as fast as they were filling them.
And do you think that's due to pay and there being wooed away by the private sector or the, non-public health section? And what do you have exit interviews? What's the reason?
Well, I don't have exit interviews. I would love to get a hold of that information and find out the exit interviews. I will say that a lot of our stakeholders have mentioned some concern over the fact that many of the public mental health system providers are being wooed away by private employers.
And do you think this is and I don't know if you can answer this, but do you think it's the same in the non-public health system section? I mean, because this is the information we'd like to find out, especially with the, essential health benefits, more individuals coming into the system so that we can avoid having the kinds of problems that we may, that brought us here today. Do you think this is also what occurs throughout the entire industry as well as a whole?
Yeah, I was just thinking about HPSAs. I have a statement here. The health professional shortage areas, or HPSAs, a designation process is, the federal government has a criteria that doesn't differentiate between providers in public clinical settings and providers in the private clinical settings. The providers are surveyed for their hours worked and the amount of Medicaid and sliding fee scale patients served. But public and private settings are not a factor in the shortage designation process for mental health or any other disciplines. So there is some work being done by the federal government in this, and that's how they're deciding their shortage areas. The mental health professional shortage areas are based on the evaluation of criteria established through federal regulation to identify geographic areas or population groups with a shortage of mental health providers. The definition of the shortage area identifies areas as having a shortage of mental health providers based on the availability of psychiatrists. So the federal government isn't necessarily going a little deeper than the parity with psychiatrists.
Okay. So and again, as you're saying that it translates still to more of the particular area, the rural, the distribution, and it's pretty much endemic to the other professions, whether it's primary care or specialty care as well?
It would not surprise me if the very shortages we're having in the mental health, the public mental health system are not the very same shortages that are happening. Probably slightly different based on economic. We do know that the largest group of providers are in the Bay Area, Los Angeles, Southern California, but that's also where the institutions are. It's unfortunate or unfortunate that people often graduate, and after those 4 to 6, 8 years that they spent depending on their profession, they've created a family there. They stay there. They don't move out. They're not willing to move out.
Okay, thank you. Seeing no other questions from any of the members, I want to thank you for your presentation. We're going to move on to the health plan and provider panel. We have Don Mordecai, MD, Director of Mental Health and Chemical Dependency Services for Northern California Kaiser Permanente. We've got Melinda Young, MD, Trustee of the Board of the American Psychiatric Association. And yes, two comments. Senator Bell earlier asked, and I don't know if they're still here, if we can have Department of Managed Healthcare as well as Department of Insurance, and if not, we'll follow up with their offices, provide the statement that they came with, the written statement that they can provide us. Also, I'd like to make a statement that we had invited numerous plans to attend, and the only ones that responded was Kaiser Permanente, so I wanted to thank you for that as well. So with that, please proceed.
All right. Good afternoon, Senators, members of the select hearing, invited guests, and attendees. My name is Dr. Don Mordecai. I'm the Director of Mental Health and Chemical Dependency Services for the Permanente Medical Group in Northern California. I'm also a child and adolescent psychiatrist. I appreciate the invitation from the Senate Health Committee to speak with you today. I did want to express my condolences for the Reagan family's loss, and I did want to appreciate Patricia Wenzel for her story and sharing that, and also the work of NAMI throughout the state and throughout the country. I think it's very important work that they do. As a psychiatrist, I'm very familiar with the challenges that American mental health care system faces. Kaiser Permanente is not immune to those challenges, and we take very seriously our responsibility to find solutions and provide leadership to meet them. We've listened to our patients, our members, our customers, and to practitioners, as well as experts inside and outside of our system, and we've established a vision for our behavioral health program that has 3 elements. First, we want to have the best mental health and addiction care programs. We're pleased that the Department of Managed Healthcare has approved our parity filing, and that respected third parties have confirmed the quality of our care. Second, we want to bring excellent behavioral health care to all who need it, including those who will not go to a mental health specialist because of stigma or for other reasons. And this is an important point, sort of near and dear to my heart, because most of the people who require mental health care will not go to specialty mental health care systems, often because they feel stigma or they don't have the access to them, as we just heard from this panel, because they're in a rural area or something like that. I think work needs to be done around integrating care into primary care, and it requires integrating culturally sensitive and high-quality behavioral health care into primary care settings, where patients are more likely to be seen. We do have integrated, technologically advanced, and team-based care, and we feel well-positioned to do this kind of work, but I think it can't just be us on that. Third, we want Kaiser Permanente to be the best place to work for mental health professionals. The recent contract agreement we've reached with our mental health therapist staff provides market-leading salary and benefits for our mental health provider employees. We've increased our mental health therapists providing individual therapy by the equivalent of almost 500 full-time equivalents between January 2011 and June 2015, and that's gone well ahead of our membership growth. At the same time, while we're hiring internally, we have expanded our external capacity by adding over 4,000 network providers. We have created systems and processes to monitor and ensure timely access. We're building the principles of feedback-informed care or outcomes, and Senator Hernandez, in your opening remarks, you mentioned how are we going to measure what we do, and I think that's extremely important. I think mental health has not been particularly good at actually measuring the outcomes of what we do, and we're committed to building that into our care, really measuring the impact of what we're doing. So we're building that into our care pathways to ensure that we continuously measure the effect of the care, and that's really crucial for all systems, again, not just Kaiser Permanente's system going forward. We're using our unique capabilities based on integration and a shared electronic medical record to focus on proactive intervention and prevention. For example, we have established workflows to identify in real time patients in our emergency departments who are at risk for harming themselves. We screen all pregnant women for peripartum depression, and we address substance abuse among pregnant women right in our obstetrics clinics, and that's an example of bringing behavioral health care into primary care settings where the patients are. We are engaging with organizations in the community, such as Stanford and UCSF, to help shape the growth, education, and training of the behavioral health care workforce. We have our own very large training program where we train over 100 mental health professionals every year, and many, if not most of them, go on to practice in the state of California. We're very proud of that program. But as we've heard today, in numerous ways, there is much that's yet to be done. There's been a steady erosion of psychiatric inpatient bed capacity across this state. The shortage is especially acute, as Patricia Wenzel talked about, for inpatient beds for children and adolescents. While Kaiser Permanente is generally able to contract for the necessary bed space for our members, we're concerned about the availability of beds for those who are outside of our system, and I think that's a very serious challenge, especially for children, especially for those who are uninsured despite the ACA, and those insured by Medi-Cal. Many counties have struggled to provide adequate coverage in their systems, especially for addiction treatment, and we remain concerned that the capacity in public systems of care is simply not adequate to meet the growing demands on those systems. Finally, for my remarks, we wanted to announce that we've established a partnership with the Steinberg Institute to work with stakeholders to develop consensus on public policy issues related to behavioral health care services. As all of you are certainly aware, Darrell Steinberg founded the Steinberg Institute. He is the former Senate President pro tem, and he did it to encourage legislative champions to help solve disputes between mental health stakeholders, to evaluate the impacts of current investments, and to implement a tangible vision to advance behavioral health services. So together with the Steinberg Institute, we've committed to convening 6 meetings that will bring together stakeholders in California to address key topics in mental health. We look forward to this new partnership, and we are fully committed to the work ahead. Thank you.
Thank you. If you can state your name and proceed. Next speaker, please.
Thank you. Good afternoon. My name is Melinda Young. I'm a child and adolescent psychiatrist with a private practice in Walnut Creek, California. I have been there for 14 years. Previously, I had a private practice in Torrance, California for 13 years. I'm a member of the California Psychiatric Association, where I sit on the council. I'm also a member of the American Psychiatric Association, where I sit on the Board of Trustees. However, I speak here today for the California Psychiatric Association, not for the American Psychiatric Association. I will note, however, though, that the failure of mental health parity is a nationwide problem. That is recognized by the American Psychiatric Association, which is actively partnering with state psychiatric associations to address the problem. An example of that partnership would be the American Psychiatric Association partnering with the Connecticut Psychiatric Association, where they are together suing Anthem Blue Cross for parity violations. Let me speak to my experiences as an outpatient psychiatrist. I work with patients all the time to help them access their mental health benefits, and this is extremely frustrating and quite often very unsuccessful as an experience. From the first contact, we need to focus on how they can get care for their children. Since January of 2014, patients still finding difficulties with accessing mental health care are no longer finding them due to rejection for psychiatric diagnosis, but they are still finding the same kinds of impediments to care, or at least the same numbers of impediments to care. Now what they're seeing is difficulties in actually accessing their contracted or approved benefits. This often has to do with rejections for intensity of care, difficulties with what is defined as 2 procedures in one day, where the plans will view an office visit and psychotherapy as 2 procedures rather than 1. Imagine seeing your dermatologist who takes off a wart and the plan refuses to pay for those 2 procedures. That's what is frequently faced by psychiatrists. Also, the frequency of appointments is regularly questioned, even for the very sickest of patients. I've had to forward multiple clarifications to plans, oftentimes including my specific progress notes for each and every visit. And I can assure you that my medical and surgical colleagues do not do that. They can provide information in general. Their progress notes aren't required. The general response that I get as I seek a clarification or as my patient runs into being denied care is, and I quote, "The documentation submitted for dates of service does not support the procedures billed. Therefore, these services would not be medically necessary," end quote. Families are referred to their policy for a definition of medical necessity and find there that it is definitely not specific. They never receive further explanation. I contact the plans, and I cannot get guidance either, except that I am told I need to document deterioration or complexity, although they don't tell me how to do that, and any way I've tried is generally denied. Denials are common. Families then take their appeals to the first level without further clarification and without knowing what will help that appeal stand up. And I have a very difficult time supporting them because I don't know any more than they do about what's necessary for the appeal. And they're still denied. After this first round of appeals, what I've found with my patients' families is generally they quit. They change insurance plans sometimes. Those who can will stop submitting requests for reimbursement and will pay out of pocket. Some drop out of treatment entirely, and some will go see their pediatricians for medication only, which amongst all of these options, I find almost the most bearable, because then I can consult with a pediatrician and see the patient intermittently, but help guide the pediatrician for the work that he or she is doing. One family, though, has been particularly successful. They've taken their appeal beyond the second appeal and got the result they were looking for. But I must note, both parents are college graduates. One has a PhD and one has a master's degree. The father, who holds the insurance, is an executive at a very large and successful financial firm with an even larger, it would seem, human resources department. Using the HR department and then hiring an independent legal consultant, 6 to 9 months later, they finally achieved coverage for their son. And another 6 months after that original appeal was successful, they finally got retroactive coverage going back to the beginning of the appeal process. These are wealthy, well-educated people. They were able to see it through. They are the single example of a family amongst many, many families I see who have been wonderfully successful, but they had the time, they had the education, they had the money, and they had the wherewithal to follow it through. For patients and for families who may not yet be my patients or anyone else's patients, I work with people simply trying to access benefits, and often on the phone. I've got at least 5 calls a week coming in. Many say they've tried dozens of psychiatrists on their insurance panel. If they can find someone who's on the panel, I'm a child psychiatrist, so if they can find someone on the panel, the doctor often is not board certified or board eligible as a child psychiatrist. If they can find someone on the panel who is board certified or board eligible, the first visit is often weeks and weeks and weeks or perhaps months away, and the drive is often either very, very long in miles or very, very long in hours. I'm in the Bay Area, and miles and hours don't necessarily equate. I teach families on the phone, these are families who are not my patients, and my own patients about the parity law and what it means, and I coach them through how to use their insurance. I've created instructions lists and a template that I share with patients as well as with non-patients that instruct them how to go forward to access insurance. I am lucky enough to be married to a healthcare attorney who has helped me word these templates, and so they oftentimes do get the attention of the recipients. But that's taken a lot of work on my part and on the part of others. And that extends to my patients and people I speak to on the phone, not necessarily any farther. What I tell them is to start, of course, with their insurance company's provider list that's online. What they need to look for is a psychiatrist board certified or board eligible? What's the proximity to home? 20 miles, 30 miles away or farther? How long does it take to get to that first visit in time? And I tell them, keep records. Record everything. Then call the insurance company if they're not successful and ask the same questions and document all of the information. Document whether or not the phone number is accurate. If someone answers, is this a real representative of the physician they're trying to seek or not? And how long does it take a real person to answer the phone? How long are they on hold? And then the same questions I already noted with the plan online. Do you have a board certified or board eligible psychiatrist, child psychiatrist? What is the proximity to home? How long for the first visit? And document it all. If they're still stymied, and often they are, I coach them to say to their insurance plan, I pay my premiums regularly, and I pay them with a good faith expectation that you will provide the medical care that I need. If you don't have an appropriately trained psychiatrist, at an appropriate distance and with an appropriate period of time, then please provide out-of-network for my child's care at in-network reimbursement and in-network rates. And when they're still stymied and they've tried to find provision for a single case agreement, I tell them the next step is to move on to the HR department of the employer. There aren't always big HR departments, and so that's not always successful. And then the next stop for the patient and family would be the state assembly member, the state senator, the Department of Managed Health Care, and the Department of Insurance. However, this has required so much time and so much effort, and it is so complex that many don't get that far. Access to psychiatric care is abysmal. I can give you an example of a colleague in San Francisco who fields at least 12 calls a week from potential new patients. He has very few openings, and because he only works with specific plans, because he cannot take them all, there are people who do have insurance who can't get in to see him because he doesn't accept their plan. Others who do have the plan that he accepts may have to wait 6 to 8 weeks, and even then, that's not guaranteed. Sometimes there's so many calls in a single day, he can't return them all, nor can his office staff. And this is in San Francisco. I'm in Walnut Creek, so there's not quite as much pressure. But this is in San Francisco, and if we think about what it's like in these rural counties, that's far less good than an already terrible situation. This is a system that's designed to fail when the odds are stacked against patients in this way, or patients' families in this way. These are patients who have severe anxiety or severe depression, or they've got severely disturbed kids, and they are not able to manage the work of finding someone to see because of the time commitment or because of the complexity. There is something very, very wrong with this system. At the very least, plans need to be upfront when someone contacts them. They need to answer the phone. They need to step up and provide several referrals who can provide to their child timely access to appointments with a professional of the appropriate training. If an outpatient psychiatrist is found, if care is authorized, and if care is paid for, we still have failure of parity coverage when we look at reimbursement rates. I don't have those rates for California, but the American Psychiatric Association has provided them in 2 other states. For the most common of the billed procedural codes for psychiatry, say 99213 if you're interested, if we look at the state of Florida, Blue Cross Blue Shield, the reimbursement for that particular code for a Medicare patient is $75, for a psychiatrist, $72, and for any other physician who is not a psychiatrist, $131. This is for the same procedure code. The procedure code defines the intensity, the length of time, and the complexity. And so the difference between what a psychiatrist receives at $72 and $131 for any other physician who is not a psychiatrist makes it clear that there is a deterrent for individuals going into psychiatric care, as well as other issues that are roadblocks. In the state of Connecticut, if we look at Anthem, Medicare payment for a psychiatrist is $78, and actually Medicare payment for anyone for this procedure code is $78. For a psychiatrist, it's $74, and for a physician who is not a psychiatrist, same procedure code, it's $86. The discrepancy is not as large, but it still exists. This is a failure in parity. It's clear discrimination in reimbursement rates, and it is pushing psychiatrists to move to out-of-network provision of care, which we don't need. That's making it even more difficult for patients to be able to utilize their insurance. Despite the noted discrepancies in reimbursement and the excessive complexities, we still note broadly in looking at data across the U.S. that about 3 out of 4 psychiatrists do take insurance, and this would be insurance across the broad range of insurances, including Medicare, Medi-Cal, other public insurance, insurance obtained through the exchanges, and other kinds of private insurance. And even among psychiatrists who who ask for direct payment from their patients, the majority provide receipts for patients to use as claims to facilitate reimbursement and work with their patients to access their contracted care. I do that all the time. I see fewer patients because I spend more time on the phone trying to help people access the care they have, the care that's been approved, and the care that's then not reimbursed once the claim is submitted. Inpatient psychiatry is even more difficult. Inpatient access to care, of course, depends on the number and the availability of beds for individuals who have psychiatric illness. Some patients who need various levels of post-acute care occupy beds that could be used for new inpatients, but they're there simply because of the dearth of post-acute facilities and post-acute beds to transfer them to. So there's a blockage downstream. The Hospital Association can provide data on the decline of beds over time. Some hospitals report holding patients who no longer need that intensity of care for months, not days, not weeks, but for months, before they can be transferred to an appropriate step-down care. We think this is a parity issue. Fiscal support for a psychiatric bed is gravely prejudiced against those beds, which must have something to do with why we have fewer beds. It is widely recognized that psychiatric beds receive something on the order of 50 cents on the dollar compared to the rack rate for roughly equivalent med-surg beds. The difference is discriminatory, and it is unjustly linked to the decline in mental health coverage. If we look upstream from these acute beds, patients are also backing up in emergency rooms, where we have patients setting records for stays in the emergency room of 71 days, 90 days, according to colleagues in the hospital and emergency physicians. When I was in training almost 30 years ago, if we had someone who had a heart attack and had to keep them within the emergency room, it was a crisis if they were there for 6 hours or 12 hours. We could still provide the care that was necessary, not in the right place, but the care was there. That was for hours. That is not for days, weeks, and months. The root causes of the inadequacies to access are diverse. Lower rates for psychiatrists for similar CPT codes or exactly the same CPT codes, excessive audits of higher intensity of care, which makes treating the seriously mentally ill very difficult, excessive medical necessity denials, more rigorous and frequent utilization reviews for mental health, more frequent denials across the board, fewer inpatient psychiatrists because some are forced to move outpatient since reimbursements are not appropriate. And then post being granted care by insurance plans, there is the attempt at clawback, the attempt at returning the money because of post-care denials, which do occur. Prior authorizations are very difficult to access, much in excess of my medical and surgical colleagues. Pharmacy benefits are difficult, and the decline in mental health beds, as I already noted, particularly in acute as well as in subacute beds. All of these are just a part of the diverse causes of the inadequacies of access for mental health patients. So what are the potential and real long-term effects of failure of parity? They're clear. At times, it's no provision of care. At times, it's provision of inadequate care. Higher costs to mental health utilizers, sometimes double co-pays, where it is viewed that there are 2 procedures in one day simply by talking to a psychiatrist as well as having psychotherapy. Pushing psychiatrists out of networks, so patients, if they're going to receive care, need to pay out-of-network rates. Failure of plans to provide a single case agreement so that these patients will be reimbursed at in-network rates when they can't find in-network physicians. Patients are not receiving an appropriate standard of care for mental health and for mental illness. They are not receiving parity in coverage for mental health and mental illness. Despite the parity laws, and despite what I've heard today, and I've listened very carefully to those who have already testified, real parity has not yet been achieved. Thank you.
Thank you. Any questions from any of the members?
Did you want me to go next?
Oh, I'm sorry.
Dan Rockers.
You were in a completely different category, so I was going to call you. But
No,
we're,
she's not. There's just an error in
oh,
there.
it was, I just found out it was her error. She put,
Oh, boy.
she,
Throw the staff under the bus.
well, no, there was a Roman numeral next to your name, and I was going to call you up.
Oh, I got my own space.
You have your own, but I'll tell you what.
It's a different one. It's a different one.
Look at this one. Here, pass this over there.
Ed, that's just for you.
I want you to clarify this.
There is a new Roman numeral by Dr. Rocker's name, that is correct.
Uh-oh.
I'll send you mine so you can see that on mine.
I got mine.